The next is about the tumors of the genital system, and in first part would be about the female genital organs. Now, among those tumors of the female genital organs, the first of the thing, comparatively less common, but casually because we are referring to it, we will discuss each of them. The first is the vulvar cancer. Vulval cancer is the fourth most common gynecological cancer and contains 5% of all malignancies of the female genital tract. The after cancer of the uterine corpus, ovary and cervix. In fact, majority of the patients of gynecological malignancies, they are of the uterine body or ovary or the cervix, and the vulvar cancers are comparatively less common, and they are histological types, and among them squamous cell carcinoma of the vulva is the most common, and about 95% are squamous cell carcinoma. Others which can occur occasionally are melanoma, sarcoma or basalioma. In India, vulvar cancer accounts for about 2000 new cases each year, and vulvar cancer is diagnosed most often in women in their 60s and 70s, in the old age. So it's more commonly in the disease of the old age, and the most common type of vulvar cancer in India is again the squamous cell carcinoma, based upon the references. References are there. Now, it can be distinguished into mainly two categories. One is produced due to human papillomavirus infection. So, human papillomavirus HPV infection is supposed to be responsible for many disease conditions. Among them, carcinoma cervix carcinoma is one of the most common issue. Then it also can involve the liver, it also can involve the lungs and so on. So, teratogenicity or malignancy induced due to HPV virus HPV virus infection is one of the major issues which we have referred to earlier in the initial classes. Again, going back to that issue, particularly in the genital organs, the incidence of human papillomavirus induced infection is quite common, and it's often seen in younger patients of 35 to 65 years of age. And the recent review pointed that 15% of all vulvar cancers develop in women under the age of 40. Now, this is the point of a bit of debating issue. According to the other data statistics, majority of the cases are in the older age, 60 to 70. But these days, the HPV virus induced vulvar cancer conditions are seen in a younger age. And the other variety is vulvar non-neoplastic epithelial disorders, which are actually degenerative pathologies or changes in the mucosal or cell epithelial characters of the vulva, which usually occurs in the older age, 55 to 85 years, and it has a slow rate of growth, and it's maybe again there is a issue like whether it's a HPV virus induced or HPV virus negative. Now, HPV virus negative vulvar cancers they usually occur because of the itching, severe pruritus by lichen or itch scratch cycle due to continuous irritation and itching. There could be changes in the skin, the epithelial tissue, and that squamous cell becomes overgrowth, hyperplasia, and it may become malignant, and this kind of lesion is called as a non-neoplastic epithelial disorder, or maybe mild invasive neoplasia. That's the other category as such. The most common described symptom of vulvar cancer is itching, pruritus, itching at the genital area, which is most frequent clinical symptom, and particularly when it occurs in the old age, that has to be carefully observed. And less frequently, the reported symptoms could be bleeding from the vulva, dysuria, burning sensation during the maturation, discharges or pain, and the most obvious manifestation of vulvar cancer is a lump or a mass. There could be a mass which may be ulcerated or leukoplakic or warty. That could be any form, like either it could be a ulcer which is indurated, or it may be leukoplakia, like whitish color changes over there. Squamous cell carcinoma accounts for approximately 95% of the cases. As per the American Cancer Society data, 6,100 new cases and 1,550 deaths occur every year, almost every year, and 2021, this is the data, and more than 90% vulvar cancer as squamous cell carcinoma. That's about the issue. Now, The clinical presentation of the vulvar cancers could be, as I told you, it could be either the mass or leukoplakia or fleshy. See, the appearance when clinical examination of the vulva often can give you the appearance like there could be an ulcer as such, or necrotic changes with the mass effect which could be seen, or there could be the changes which could be seen in the epithelial character like cicatrization, also could be representation of the vulvar cancer. Whenever the appearance of the vulva gets altered like this, and you have the typical appearance of the leukoplakic lesion, that whitish lesions as you see over this, these have to be considered, and majority of the patients whom we see, they come with either leukoplakic phase or with the ulcerative lesions in the vulvar area, or it could be a deep ulcer, huge ulcers, which also could be the presentation of the vulvar cancer. Now it's important that they have to be differentiated from other benign vulvar lesions. The other benign lesions which are not really malignancy could be lichen sclerosis. Lichen sclerosis is where the skin becomes thickened throughout, not at the edge of the vulva alone. It could be over throughout the vulva, and there could be some secretions over there. Or irritant dermatitis due to the physical contact, either with some chemicals or maybe the dress materials. There could be itching which can extend beyond the vulva, and the skin may become inflamed. Or allergic vulvitis, extensive allergic pathology which can also produce the vulvitis, often again due to the chemicals which are usually applied over the area. And Haley disease is where there could be again something like a fungal infective pathology, where there could be eruptions over the area. Or pemphigus vulgaris also can present with ulcers, superficial ulcers, or epidermal cysts which are superficial. They need to be differentiated from the vulvar cancer. And hemangiomas or papillomas also, they have to be differentiated from the vulvar cancer. Or labial hypertrophy also could be a presentation which may produce confusion with the vulvar mass. So they need to be differentiated by careful examination. Once the suspicion of the diagnosis of vulvar cancer is done, it's necessary that you have to go for the biopsy and confirm it. And the staging of the vulvar cancer is staged into 4 stages based upon whether it's limited to the area of the vulva, like where it's involved only in the perineum between the, and doesn't go beyond the perineal area. And if it goes crosses this perineal area and spread to the urethra, anus or vagina, then it is called a stage 2. And can, if it has spread to the lymph nodes nearby, then stage 3. And if it has crossed the primary groups of the lymph nodes and it has spread into the other parts, it is stage 4. That's how it has to be differentiated. The early disease is defined as stage 1 or 2, and these patients' treatment would be in such conditions. Surgical excision, including adjuvant treatment, is based on the findings at the time of the surgery. Like that's if the lesion is not completely excisable, a follow-up treatment with the adjuvant treatment is necessary. Otherwise, stage 1 or 2 could be managed only with the surgical treatment. Locally advanced stage 3 maybe treatment is operative treatment when it is possible, and they may require chemo or radiation. Stage 4 and the extensive diseases, there is treatment is a primary chemotherapy, and the systemic treatment and palliative treatment may be the options as such. Prognosis of patients with vulvar cancer is quite good when convenient treatment is provided in a timely manner. Inguinal or femoral node involvement is the most significant prognostic factor for survival in patients with vulvar cancer. Extracapsular growth of the lymph node metastasis, 2 or more affected lymph nodes, and more than 50% replacement of lymph nodes by tumor are predicts of poor survival. The overall 5-year survival rate ranges from 70% to 93% for patients with the negative nodes, and from 25 to 41% for those with the positive nodes, based upon a wide study data. Now this I have just copied from the sources which predicts the prognosis. All that summary is, if the condition is diagnosed at an early stage, it is surgically resectable, and surgical resection is a better choice of the treatment which can extend the life of the patient. The next variety of the tumor, again comparatively less common, is vaginal cancer. According to the FIGO, that's the Federation of Gynecology and Obstetrics, a vaginal lesion involving the external os of the cervix should be considered cervical cancer and treated as such. So, differentiation between the vaginal cancer and the cervical cancer is defined by the FIGO as when the lesion is limited to the external os of the cervix, then it's a cervical cancer. When it involves the vulva and the vagina, then it will be considered as either vulvar cancer or vaginal cancer. 80% of the vaginal cancers are metastatic. So, primarily the vaginal cancers are less common. Majority of the patients are having the tumor either in the vulva or they may have an extension from the cervix, and vaginal cancers are primarily due to the metastatic pathologies, majority of the conditions. And primary vaginal cancers are defined as arising solely from the vagina with no involvement of the external cervix, os or proximal of the vulva distally. Now this is purely based upon the clinical examination and confirming that there is no involvement of the vulva or that of the vagina, then you call it as a primary. Otherwise it is also considered as metastatic. Primary vaginal carcinoma is quite rare, constituting only about 1 to 2% of all malignant gynecological tumors. And histological types of the vaginal cancers are, again, squamous cell carcinoma is the majority, which is seen in 85 to 87%, and usually seen in old age like 60 years or beyond that. And the spread would be local by a local spread or bloodstream or lymphatic, and usually seen in the upper third of the vagina, the superior third of the vagina. Verrucous carcinoma is rare and it is seen in, again, old age, and the spread is only locally. Usually the appearance would be cauliflower-like appearance, or radiotherapy is not needed. Simple local surgical treatment would be enough. Then clear cell carcinoma is one more, adenocarcinoma is one more, which is compared to less common and seen in younger age. So when a vaginal lesion is seen in younger age, it could be adenocarcinoma, and it also spreads through the bloodstream and often is due to exposure to diethyl stilbestrol or contraceptives or hormonal drugs, and usually it's presented as a cystic pattern and has a better prognosis. Risk factors which can induce vaginal carcinoma are HPV infection, again human papillomavirus. So human papillomavirus is one of the major responsible conditions for a majority of the gynecological conditions, and of course we will have more detail about this issue when we discuss about the cervix carcinoma next part. And the subtypes of these human papillomavirus 16 and 8 have the highest oncogenic potential, and other infective agents like trichomonas also or herpes simplex also is considered to be one of the risk factors for the vaginal cancer. The other well-known risk factor for vaginal cancer is having multiple sex partners or sexual promiscuity, or hormonal drugs like diethyl stilbestrol, which is usually earlier prescribed for prevention of the pregnancy loss. Now it's also used in as a contraceptive, and previous hysterectomy and long-term pessary uses or chronic irritation of the vagina mucosa with the procedentia, that with the significant prolapse of the uterus, also can result in the vaginal cancer. The common symptom is painless vaginal bleeding is the most common clinical symptom, which accounts for about 65 to 80% of all presentations. Bleeding in postmenopausal is about 70% of the patients, which is usually seen in the peak age of 60 years of squamous cell, and they are common in squamous cell carcinoma. Vaginal discharge, usually foul smelling, occurs in 30% of the patients, while 20% patients report urinary symptoms like burning sensation or dysuria or pain in the bladder, urgency, hematuria, etc. And about 15 to 30% of the patients may present with pelvic pain, which is due to the lesions which are towards the posterior side and compressing on the pelvic area or rectosigmoid junction, and they may present with the tenesmus or constipation. Only 10% of the patients may have vaginal mass or vaginal prolapse. So vaginal mass or vaginal prolapse is seen only in 10% of the patients. About 10 to 20% of the patients are asymptomatic. Diagnosis is made during routine pelvic examination. The better visualization of the vaginal wall can be done with colposcopy. Though simple speculum examination also is good enough, but with the speculum you may have some areas masked over there, and the appearance of that occult carcinoma could be like seen as the mucosal changes, like dots, like, and with the colposcopy it can be better seen. And if it is used processed with the citric acid, if you sprinkle citric acid, low concentration of citric acid, 0.5% citric acid, the lesions will be better visible in terms of these spots or maybe cicatrization. And the staging of the vaginal cancer again is staged as into 1, 2, 3, 4 and 4th AB depending upon the spread. It's a usual thing. And stage 1 is when it is limited to the vaginal wall. Stage 2 is it has involved the subvaginal tissue but has not extended into the pelvic wall. And stage 3 is when it has extended into the pelvis as such. And the carcinoma has extended beyond the true pelvis, has involved the mucosa of the bladder and rectum, then it's stage 4. And again stage 4 you will have A and B depending upon the involvement of other distant organs. And a carcinoma embryonic antigen, CA, tumor marker, is seen to be quite high in majority of the patients, and hence for screening test of vaginal cancer, study of tumor marker CEA is recommended. The option of the treatment is radiotherapy is very effective and definite treatment for primary vaginal carcinoma. For primary vaginal carcinoma, the radiation is the better treatment. But as I told you, there are relatively lesser number of primary cancer patients, and the majority of the patients come in the metastatic stage, and there the issue becomes more complicated. The patients with the stage 1 disease, the survival rate at both 5 and 10 years was around 96%, and stage 2 patients 5 and 10 years survival rates are 75 to 68%, and stage 3 patients 69 and 64%. Survival rate for the superficial lesions or 4th A lesions is both 5 and 10 years also 53% as such. Surgery with or without concomitant radiation therapy is indicated in the following conditions, like squamous cell carcinoma, stage 1 disease, or clear cell adenocarcinoma or varicose carcinoma. The surgery is indicated, and varicose carcinoma radiation therapy is contraindicated because it can potentiate the tumor into malignant phenotype as such. So that's about the vaginal carcinoma. Vulvar and vaginal carcinoma are not so common conditions, but we have just referred to it casually. But the more important from our clinical point of view in the routine clinical conditions are the cervical cancer. Cervical cancer is the third most common malignancy in women worldwide, and it remains a leading cause of cancer. And in 2022, 1,27,356 new cases of cervical cancer were reported in India. I am specific about the data in India because the incidence of cervical cancer in India is quite high and it is increasing rapidly. And according to the estimated number of patients would be by 2023, it would be 3.4 lakhs of new cases are supposed to be present in the are reported in India. And as per the burden of cervical cancer in India, again this data is mainly from India, the annual number of new cases is quite high and mortality also is quite high. Out of 1,23,000, 77,000 are considered to be fatal issues. That's because of the delay in the diagnosis and relatively lesser involvement of the treatment. Crude rate, that's the average rate is 18.7 and age standard rate is 18. Cumulative risk of for the chances of malignancy in the overall population is 2.01. So in the age of 70 years, 0 to 75 years, 2.01 percentages have a high risk of involving the cervical cancer, and when I say this female population, and the mortality could be around 1.3. And ranking of cervical cancer in globally world would be India is in the second rank. African countries are in the first rank. That's in the sense majority, the maximum number of incidences in the Africa, and the lesser comparatively next would be India, and India is in the second rank of incidence of carcinoma cervix, and hence it's more important, and we will go into some detail about that. About cervical cancer, the involvement of human papilloma virus is one of the major issue, and it's a concern of maybe throughout the world, and WHO also has some specific programs, recommended specific programs all over the world, and hence we will have some detail about the HPV virus and its types, so on. The HPV virus is not a single type of the virus, it's a heterogeneous group, a large number of groups are there, and by genome study there are around 60 varieties of them are studied. Among them, the early opening reading frame proteins like E1, E2, E7, they are considered as regulatory proteins, and they are supposed to be responsible for the carcinoma as such. And mainly there are two categories from the simplification of, instead of going into all that complex varieties of 60 varieties which are beyond the perception, I would make it as simple, and among them we can categorize all these groups into mainly two broad categories. One low risk types, usually it's named as HPV 6 to 11 subtypes of them. They are usually associated with the condylomata. There will be some condyles like which are benign, and they are low grade squamous epithelial lesions. They are categorized as not cancers, or maybe locally invasive, and they are never seen in invasive cancers. Deeper cancers, they are the HPV 6 to 1 are not seen. The cervical cancer is at least 5 times more common in HIV infected women, and this increased prevalence has remained essentially unchanged with the use of highly active antiretroviral therapy. Once the patient is HIV positive, the risk of cervical cancer is quite high. Even after the retroviral therapy, the risk is not reduced. HPV infections are transmitted via non-sexual routes too, but majority of the conditions it's due to the sexual contact. The spread is due to the sexual contact, and particularly the risks are higher when the patient would have sexual involvement at a younger age, when multiple sexual partners or promiscuous male partners. So even if the female is committed to single, if the male is having a promiscuous habit, then there could be the chances of HPV virus are more. And if the patient has a history of sexually transmitted disease of any sort, the chances of HPV virus also are more. HIV infection is associated with the 5-fold increase in the risk of cervical cancer, presumably because of the impaired immune response to HPV infections. HPV infection occurs in a high percentage of sexually active women. Almost 90% of the infections they clear on their own within 2 months, within months or a few years with no sequel. Now this is one of the important issues. You will have plenty of patients who are presented with HPV virus positive, and the cytology reports in the 2 years following infection may show a low grade squamous intraepithelial lesion. Cervical intraepithelial neoplasia, that's where there is no tumor pathology but just changes in the tissues, dysplasia pattern. They may be graded into the scales 1 to 3, and the scale is depending upon the histopathological appearance on a pap smear examination, and it's a low grade dysplasia, that's CIN1, and CIN2 is a high grade dysplasia, CIN3 is a very high grade dysplasia with the full thickness of the lining of the cervix. So when a patient is presented to be HPV positive, it has to be studied under microscope, the histopathology. Usually the pap smear examination is done, and based upon the involvement of the depth of the lesion, They are categorized into CI1, CI2, CI3. Whenever you refer a patient for the histopathology examination of pap smear, the report gets as either normal or any of the CIN number or a confirmed cancer. Confirmed cancer is when the dysplasia has gone beyond the area of the cervix as such, and the number of multiplications or the changes in the cells also are higher. And on an average, only 5% of the HPV infections will result in the development of CIN grade 2 or 3. This is again quite important. See, 90% of the patients having HPV infections, it subsides on its own, and the changes could be seen under the microscope as the CIN grade 1 to 3, and only 5% of the patients having HPV virus infections have a grade 2 or 3 lesions within 3 years of infections. So if you follow the patients, then only 5% would have these lesions. 20% of the CIN lesions, 3 lesions, may progress into invasive cancer within 5 years. So if a patient has a CIN 3 grade, the chances of that patient developing a cancer, cervical cancer, in 5 years is just 20%. And only 40% of the CIN 3 lesions progress to invasive cancer within 30 years. So if you have a follow-up of 5 years and 30 years, the chances of developing a malignancy is just 20 to 40%. Now, these data are quite important because when a patient presents now, these days the people are quite aware of the HPV issue, and lots of, I will come back to that part also. Lots of questions come up in the clinical practice, like once a patient has HPV infection, there is a lot of concern issue. That the concern issue and the risk prediction is one of the important factor which we have to deal with when we deal with the patients. And when the patient has a HPV positive, and if the pap smear shows only CI1 or maybe no changes, there is absolutely no issue for concern, and usually I consider them as a simple treatment, and usually I manage with the Chandraprabha Gandhakarsayana Ushirasava such treatment without much of awe about it. But if the patient has a high risk category like a promiscuous sex habit, early sexual active involvement, or such issues, then the patient has to be considered as a high risk patient, where you have to go for the advanced approaches or maybe detailed approaches. Then because only a small portion of the HPV infections progress to cancer, the other factors which we have to consider also is quite important, and to assess the prognosis or maybe carcinogenesis. And the factors which you have to consider are type and duration of the viral infection. Now, studying the type of the organism, viral organism is an advanced issue. You have to go for the genome study, and in the genome study, if it is HPV1 to 6, then or E1 to E6, then the risks are more. If the otherwise the risks are lesser. So that's how it has to be, which is again a bit advanced job, which routinely we may not do as such. It also depends upon the host conditions that compromise immunity, like poor nutritional status, immunocompromised conditions, HIV infections, they increase the risk as well. Environment factors like smoking and vitamin deficiency, lack of access to routine cytology screening, if the patient is not able to have screening regularly, in such cases also it is considered a high risk. This is from the theory point of view, whereas from our practical point of view, I will be focusing on this issue like early age of first intercourse, and the multiple sexual patterns or sexual habits, which are quite issues as such. About cervical cancer, WHO has given the key facts about these issues, and because it's a global concern and the incidence is quite high. Cervical cancer is the 4th most common cancer in women globally. Now I have just copied it as such from the WHO guideline, and it's important that we have to know about it. 6,60,000 new cases and around 3,50,000 deaths in 2022. This is a global WHO data. Highest rate of cervical cancer and mortality are in low and middle income countries, including India, and this reflects major inequities driven by lack of access to national HPV vaccination. Now, WHO is insisting on HPV vaccination as a mandatory. In India, it's not yet mandatory, but maybe in a few years, HPV vaccination may become mandatory. I will come back to that part And cervical screening and treatment services also are considered to be one of the standard protocols which have to be implemented according to the WHO. Maybe these protocols also may be involved in the National Health Program in due course of time in India also. Cervical cancer is caused by persistent infection with the human papillomavirus. Women living with the HIV are 6 times more likely to develop cervical cancer compared to women with the HIV. Prophylactic vaccination against HPV and screening and treatment of precancer lesions are effective strategies to prevent cervical cancer and very cost effective. This is what the WHO says. And cervical cancer can be cured if diagnosed at an early stage. Countries around the world are working to accelerate elimination of cervical cancer in the coming decades, and with an agreed set of the 3 targets to be met by 2030. And the target is just 4 patients per year. That would be the target. The global strategy of the WHO is elimination of reducing the number of new cases annually to 4 or fewer per 1 lakh women, and sets 3 targets to be achieved by year 2030. And those 3 targets are which are now recommended to all countries including India, and there is a lot of WHO pressure to follow this in India also. So there is our national policy makers, they are contemplating on that. Still it is not yet made mandatory, but within a few years or maybe in a short duration there will be a mandatory issues related to HPV vaccination in India, and that target is 90% of the girls should be vaccinated with HPV vaccine by age of 15. 70% of the women should be screened with the high quality test by ages of 35 and 40. 90% of the men with the cervical disease should receive the treatment. This is the WHO target, and the health policy now makers, they are targeting at this issue in India also. So we should be prepared for that. Now, HPV infections and cervical precancer conditions, abnormal cells of cervix, can lead to cancer, have dropped since 2006 globally. And the HPV vaccines were first used in the United States as such, and after using this HPV vaccine, they are now considered to be very effective. Based upon the data from CDC, the HPV infection causes about 88% of the genital warts have dropped now comparatively after using HPV vaccine. In USA, that HPV vaccination by age of 15 is mandatory, and after that 88% of the genital warts have dropped, and the genital warts again have dropped in adults by 81%, and among vaccinated women, cervical precancer stages are dropped by 40% from 2006 onwards. So in USA, 2006 onwards, the HPV vaccination has become mandatory, and current guidelines throughout is for the screening of cervical cancer below the age of 21 years, no screening is recommended. 21 to 29 years, a pap smear cytology alone every 3 years is recommended as a routine thing. 30 to 65 years, if the patient has a primary high risk human papillomavirus testing every 5 years, it has to be done every 5 years, and cytology co-testing every 5 years, or cytology alone in 3 years. Above 65 years, no screening is recommended if adequate prior screening has been negative. Now these days HPV sampling or test also is done as a homemade test, and in India also now lot of these software people, they are now worried using this. It's available online also, that HPV self-examination kit, and this is one of the issue. In Amazon you can get it 1,800 rupees. Self-examination kit for HPV virus is available, and these days it has become a fashion or whatever it is. Now once the patient comes in, now this is one of the practical problems which we see in the clinical practice. Patients come with the self-examination or maybe some other examination where HPV virus is supposed to be positive. Then what should be done? The standard protocol for such conditions is, if the patient is HPV negative, the standard protocol is rescreen after 5 years. If the patient is positive, then treat with either cryotherapy after determining the eligibility for the possibilities, considering that risk factors. If the patient is having a high risk factor, or if there is some changes which are visible in the area, or if there is a proved one cancer like the cytology is also is supportive, then you have to go for the cryotherapy. If the patient is not having the cellular changes, then you go for the further examination either with the cytology or simply visual inspection. Now, visual inspection of the cervix is one of the important protocol by which you can make out the chances, and this and the direct colposcopy is, these are the three things which are suggested. Colposcopy we may not do regularly in our routine clinical practice. Cytology with the pap smear is the one standard protocol. Now, from our clinical point of view, when a patient has a cytology and the cytology study is having a low grade CIN1, then I would be treating that patient with the Chandraprabha Gandhakarasayana Ushirasava, or maybe Khadirarishta occasionally. Then if the visual inspection is positive, suggests of a possibility, then I would always advise for this biopsy, further deep biopsy. If direct colposcopy, of course, we get a few patients with direct colposcopy, and there again it also can show the risk as such. Now, visual screening, the changes which can occur in the cervical cancer, these are again released by WHO as a standard atlas, visual screening atlas in the cancer screening of IARC released by WHO. It's presented as atlas. The changes which can occur could be edema or hyperemia or irregular surfaces, and hyperemia with the irregular surfaces, and advanced erosion, cervical erosions of different degrees. Now, these are the erosions seen, or local swellings over the cervix with the again bluish discoloration, and the cervix os becoming somewhat wider opening. These are the possible changes which may occur on the cervical examination and visual examination and the simple speculum examination. Colposcopy also shows the same changes in a much better way. Now, that's about the issues. Clinical symptoms of cervical cancer are mainly a foul-smelling vaginal discharge, persistent pain in the back, legs or pelvis. Patients presenting with the usual discharges, white discharges in the vagina, and then they have complaints of pain in the back, legs or pelvis. You have to be careful. It could be a cervical cancer also. Pelvic infections do present with the pain in the back, and if it is persisting, and particularly with our conventional treatment like Chandraprabha etc., if it doesn't reduce, then you will have to think of this issue. The malignancies have to be ruled out. If there is a history of weight loss, fatigue or loss of appetite, patients have history of vaginal discomfort, swelling in the legs. Swelling in the legs is one of the most serious issues in patients with the suspected cervical cancer, because it suggests of involvement of the deeper area. As the tumor grows, it extends into the epithelial surfaces, and it also involves vaginal epithelium, and it spreads to the pelvic wall. So the area becomes wider. So when you examine, if the changes are seen in the vaginal vault or the pelvic wall, vaginal epithelium is also altered, that suggests of an invasion of the cancer, a spread beyond that. It can invade the bladder and rectum directly also, leading to the symptoms of constipation, hematuria, fistulae or urethral obstructions, with or without hydroureter or hydronephrosis. And most important are leg edema, pain and hydronephrosis suggests of pelvic wall involvement, which is again more serious concern, suggests of a very serious issue. The common sites for distant metastasis include extrapelvic lymph nodes, liver, lungs and bone. Once the patient has the HB virus positive and pap smear doesn't confirm the pathology, then the next level would be cervical conization. Cervical conization is one procedure where you remove the tissue either with a scalpel or with the laser beam from the cervical os and send it for biopsy. Histopathology study is done of these tissues, and that confirms the lesion. The investigations which are to be done to confirm the diagnosis of cervical cancer, radiological investigations have a lesser this possibility of making the diagnosis. But once you have diagnosed the condition, to predict the prognosis and the spread of the disease, the radiological investigations are required. In case of MRI scan, the MRI would be positive, would be visible only when the tumor has reached the stage 1B or above. So early stages of the tumor may not be seen in MRI, and but still it is considered as the choice of imaging modality for primary tumor assessment. The distant metastatic disease also is better assessed with the CT or PET scan. Ultrasonography doesn't confirm the primary, doesn't help in confirmation of the primary, but occasionally if the size of the tumor is quite big, then tumor mass may appear as a hypoechoic or isoechoic lesion with undefined margins at the cervical area. But the ultrasonography could be effective to evaluate the size of the tumor, if the confirmed tumor, and it also may be showing the effect of the uterus size, and there again transvaginal ultrasonography or transrectal ultrasonography is preferred. A MRI image, I have given a few examples. MRI image of the carcinoma cervix, the uterus body, and at the cervix that erosion is seen, or the irregularity of the cervix area in MRI scan can be seen as the evidence of the primary. Ultrasonography, the bulky uterus with the cervical erosion occasionally can be seen. Transrectal ultrasonography also shows the uterus and the same changes in the cervix as such. So that's about the issue. PET scan can help in locating the primary as well as possible secondaries also. So PET scan is an option. Staging of cervical cancer is again by the FIGO, and the FIGO staging is from stage 0 to stage 4B depending upon the involvement of the neighboring issues. Carcinoma in situ is stage 0, invasive carcinoma stage 1, and only diagnosed with the microscopy, but there are no other clinical evidences, stage 1 again. There again the microinvasive carcinoma less than 3 mm, stage 1A1, or it could be 5 mm and depth is more, less than 7 mm, stage 1A2. Stage 1B is clinically visible, and or microscopic lesion of 1A2 like, or again there you have 1B1 and 1B2 based upon the size of the lesion. 4 cm is a level. Stage 2 is if there is extension beyond the cervix but not to the vaginal wall, or involvement of the upper 2/3 of the vagina, that's a 2A, and parametrial involvement is a 2B. Stage 3 is extension of pelvic wall and lower third of the vagina with head nephrosis. Then again you have stage 3A and 3B, and stage 4 is extension beyond the 2 pelvis involving the bladder as such. The treatment options are for early invasive cancer, surgery is the treatment choice, and advanced cases, radiation combined with chemotherapy is the current standard of care, and in patients with the disseminated disease, chemotherapy or radiation provides the symptom as such. Stage 0 cancer, carcinoma in situ, it's treated only with the local ablation or excisional procedures like cryosurgery or laser ablation or loop excision. That's minor surgeries where the only involved area is removed. Stage 1A1 cancer, total hysterectomy, radical hysterectomy is suggested. Stage 1A2 to stage 2A, the treatment will be combined external beam radiation with the brachytherapy. Brachytherapy is inserting radioactive cobalt rod into the cervix, and radical hysterectomy is the pelvic lymphadenectomy. Stage 2B or up to stage 4A, radiation therapy with and then brachytherapy and chemotherapy also are tried as such. Prognosis in patient cervical cancer depends on the disease stage, and in general the 5-year survival rates are as follows. Stage 1 is greater than 90%, stage 2 60 to 80%, stage 3 approximately 50%, stage 4 less than 30%. So that's why the early diagnosis is important. And with this we conclude today. We will continue in next session about uterine cancer and these ovarian cancers.